And clear. So, good morning, ladies and gentlemen. The three of us, Dr. Ghulam Ali Kamdar, Dr. Devanshi Desai, and myself, Dr. Sanjiv Desai, we bring to you this instruction course from the lovely city of Jodhpur, jewel of the great Indian Thar Desert. So, this is a unique instruction course because low vision is actually not discussed so much in national or international fora. So that is the reason that we decided to hold this instruction course. The specialty itself is very poorly developed in our country, and that is the reason why the twin goals of this instruction course are to understand the concept of low vision and its treatment, and to develop the necessary skills to identify and treat low vision cases in your day-to-day practice. So it is interesting that in the recent years, the Supreme Court has ruled that colorblind students and students with low vision are eligible to appear for NEET PG examination. So in the coming years, you'll have a lot of low vision patients, doctor patients, student patients coming to you to find a solution for their visual impairment. So that is the reason why we need to be alive about the problem of low vision and its management. So low vision, as you all know, has got a devastating impact on the quality of life of individuals and has important socio-economic and health consequences. And that is the reason we need to treat low vision as early as possible so that we can enable these people to become independent in life, to do their normal daily tasks easily, by subjecting them to a sort of comprehensive evaluation called low vision rehabilitation, which consists of the following points, which is functional evaluation, clinical evaluation, optical and non-optical aid evaluation, patient education and instruction, and proper follow-up and post-follow-up care. But in this course, we are going to focus only on the two highlighted aspects, which are clinical examination and dispensation of optical and non-optical devices, because we are clinicians and we need to practice clinically in our clinics, and that is what we're going to do. So the goal of low vision rehabilitation is to maximize the visual potential of a visually impaired person by increasing functionality, provide link to community resources and support services, and finally to provide education about his visual problem and what to expect in the future. And this course is divided into 8 parts. We will begin with the definition and epidemiology, go on to the principles of treatment, clinical evaluation, and through to light, glare, and contrast management. And then we'll discuss finally some cool new stuff which has come up in recent years. So over to Dr. Ghulam Ali now, who will make his presentation on the epidemiology of low vision in our country. Dr. Ali. Change करना पड़ेगा.
Good morning, everyone, and thanks, Dr. Sanjiv. Let's begin with understanding the definition of the low vision. WHO first defined 6 categories of visual impairment in 1973, and they say visual acuity between 360 and 618 is considered low vision. This is a magnifying area. Highest is 618 and lowest is the less than 360. Consider low vision. That means category 1 and 2 are considered as a low vision. Because of the fallacies in the previous definition, the working group of WHO met in 1992 again and adopted category 3 and 4 to be included as a low vision. So the working definition of low vision is a person as a low vision if best corrected visual acuity in the better eye is less than 618 to PL or a visual field of less than 10 degree from fixation, but who uses or is potentially able to use vision for the planning or execution of the task. People with low vision are legally blind, and at the current point in time, no surgical and medical treatment is available to improve vision, and they are eligible for the all government benefit made for the visually impaired person. Although they are legally blind, but they are not totally blind because they have some residual vision. In one study in 1991 at Jodhpur, in blind school, that so 95% of people with low vision have some level of usual sight. Here there is no cut of visual acuity. Looking at the residual visual function in such patients, the government of India came up with a functional definition of low vision, which is a person with low vision means a person with impairment of visual functioning even after treatment or a standard refractive correction, but who uses or is potentially capable of using vision for the planning or execution of the task with appropriate assistive devices. In essence, low vision is a level of visual disability that cause difficulty in carrying out everyday tasks, and its consequences are debilitating and include patient experience loss of self-esteem, decline in general health, and increased risk of the depression, injuries, and mortality, and it incurs a lot of expenses on the government. And then the question is, why do so many patients go untreated? And answer is because of barriers to the low vision care. Most important is the lack of training and knowledge in the low vision care, a lack of awareness about low vision services, non-availability of the low vision devices, lack of motivation among the ophthalmologists and the optometrists. Low vision care is time consuming, and most of us busy in the providing general ophthalmology services, cataract surgery, etc. And low vision care is not lucrative, and low vision services are not effective in helping patient. That are our thought. So recent studies, now I come to the epidemiology part or some data I am going to share with you. Recent study by WHO has demonstrated that there are 253 million people are visually impaired, out of which 217 million people are moderate to severe visually impaired, and these are people who are required low vision devices. This is a global map showing the prevalence of low vision, and the prevalence of low vision in India is 1.6%, and it falls in the category of moderate prevalence. These are the some diseases which causes the diminution of vision. Sorry, it's not visible now. Like retinitis pigmentosa, diabetic retinopathy, chorioretinal degeneration, retinopathy, retinal dystrophies, corneal scarring, corneal grafts, etc. In this section, we have seen that we learned the definition of the low vision, and there are several barriers to the low vision which we need to overcome. Now, overcome to Divyanshi. Thank you. Very good.
Embarrassing. Okay, so I'll be talking about the principles for treating a patient of low vision aid. So we should remember that there are mainly three principles In addition, there is a fourth one also. But firstly, so the first principle that we'll be talking about is refraction. We need to know what kind of a patient, what kind of a BCVA we are dealing with before we provide any sort of rehabilitation. And to our surprise, 10% of the cases who present as visually impaired get corrected with refraction. The second principle is mainly of magnification. So it's as simple as the word is, if you can't see, either you go close or you increase the size of the object. Then the third and the most important principle is illumination. So I'll be discussing about these a bit later in the presentation. Fourth thing, which is also important as a part of illumination, is considering the management of glare as well as enhancing contrast sensitivity. So, we correct refraction by using glasses for distance and near. And like I said, it corrects 10% of the cases. For magnification, we basically use telescopes and magnifiers, CCTV cameras, and large print software devices. For correcting contrast and illumination, it's as simple. You have a dark against light or light against dark. Like as in the case of our PPT itself, it's pretty clear if you can see the white ones better than the yellow ones, right? So coming to refraction, as you can see, whenever you refract a patient with low vision, we should not use a phoropter to take out his best corrected visual acuity. We should use large frame glasses. So after giving a proper refraction, so the advantage is that it increases the visual acuity to create a very sharp retinal image. Coming to the next principle, which is magnification. As you can see on this graph right here, so the visual acuity, the further you go away from the fovea, the visual acuity tends to decrease. So what we do is we take advantage of this fact in cases of people with central scotoma or where the fovea is involved. So we try to magnify the image so that all the light that falls on this temporal or peripheral, basically the peripheral retina. So whatever little cones are there, we take advantage of those cones and we try to use it for the patient to see better. So basically, in short, it increases the spread of the image to look around the central scotoma, as you can see here in this. The downside of this is that it decreases the span of comprehension and it won't be applicable for cases of where there are peripheral degenerations, for example, retinitis pigmentosa. This is another example of, as you can see. So there's a nice flower, but a patient with low vision cannot appreciate it. So the more you magnify, the better the beauty of the flower that the patient can appreciate. So basically, it creates a blurred, imperfect, yet functionally useful image for a patient with low vision. Coming to illumination. So now, as you know, in cases where there is aniridia or albinism, where there is lack of melanin, so there will be a lot of glare in those patients. In such cases, we need to minimize his illumination or the light settings around that patient or his working space. In cases of glaucoma or pathological myopia or aphakia, we need to enhance the illumination so that we can use the residual cones better. Coming to contrast enhancement. So contrast sensitivity is the ability to distinguish an object from its background. For people with no problem in their eyes, we don't really mind what the contrast of anything is. But for a patient with low vision, his spatial orientation and his daily living skills are dependent on this very aspect of treatment. As you can see here, this is the image on the lower half is the poor contrast, but on the top half is the better contrast. So the patient can appreciate this, like if you use a white against a brown, the patient can appreciate cutting the vegetable, as in this case, much better than this. Now addressing the same thing at home. So as you can see, if you put milk in a white utensil or if you put water or oil in a black utensil, the patient won't be able to see. So you need to switch such things. Like for example, if you put milk in a black utensil or any sort of oil in a white utensil and you use it for cooking, that's helpful. Similarly, other examples like serving the food on the plate where, white against black, black against white, or any other color which has dark and light contrast. Another thing is that we should not the surroundings of a patient with low vision should not have patterns or multi-colored surroundings, so that it becomes difficult for them to distinguish. And even, as you can see, the flooring should have contrast lines. So now there are certain diseases which can be treated with low vision aids, and there are certain diseases which cannot. Common ones that we see in our OPDs are usually AMDs, myopias, albinisms and iridias, and optic atrophies. Now the diseases which cannot be treated with low vision aids are mainly hypertensive retinopathies, diabetic retinopathies, CRAOs, CRVOs, advanced glaucomas, where the retina itself is damaged in toto. I'd hand over to Dr. Ghulam Ali Kamdar now for the presentation.
Clinical evaluation, the low vision aid. Clinical evaluation is crucial for the low vision patient because it allows for a comprehensive assessment of their visual function, and which is essential for developing an appropriate treatment plan and maximizing their visual potential. A clinical evaluation involves thoroughly examining a patient's visual acuity, visual field, contrast sensitivity, color vision, and other aspects of visual function. It also includes a comprehensive assessment of their overall health, medical history, and lifestyle factors that maybe impact their visual function. And how does one perform a basic clinical low vision assessment? It is done as a regular clinical examination, but the importance is placed on the history to identify the patient's visual challenges, whether for near, far, or intermediate, or distance, and then tailoring a solution for that challenges. And the visual field is also essential in identifying scotomas as an eccentric viewing may be needed. This is the clinical form which uses for the examination and evaluation of the low vision aid. The purpose of this form is to document how a patient sees under a variety of situations, describe the visual and non-visual technique the patient presently uses to compensate for their reduced vision, and this helps the patient to become aware of when their visual needs require accommodation or the use of the sensory modality in place of the vision skill. And the visual field is a great influence on the telescope adaptation. For eccentric viewing, educational training of the telescope must be performed before prescription. For those with the concentric visual field loss, mainly for visual field less than 5 degrees, aids should be prescribed with caution. Telescopes are not so much useful in the patient who have a visual field less than 5 degrees. And the patient will have difficulty localizing and tracking the object when there is a central or paracentral scotoma with normal peripheral vision or scotoma above the fixation area. In case of low contrast adaptation to device, as mentioned by Dr. Divyanshi in our presentation, contrast adaptation to the device can also be more difficult. Early use during childhood leads to the better acceptance as compared to the teens years and beyond. And lighting needs are paramount importance to the low vision patient, and therefore it necessary to document its lighting needs. Based on this need, a patient may need an increased illumination or decreased illumination, like in increased illumination in the AMD patient and decreased illumination in the albinism patient. This is the schematic diagram. So the workflow in our low vision clinic. OPD doctors sitting in their cabins identify low vision patients from the clinical examination. Once the identified the patient is referred to the low vision service chief and ophthalmologist for the ophthalmic examination. Then the flow to the low vision optometrist, a dedicated optom for low vision at prescription and trial. Then the patient exists and is put up on the follow-up. This is what you will accomplish after taking this course. You yourself will become skilled in examination and prescription of devices. right? If single doctor clinic, so your clinic, then you and the clinical evaluation prescribing low vision devices and patient exit from the hospital. And we have learned in last presentation is the point in clinical evaluation of the low vision client and record keeping of the low vision patient. Thank you very much.
Oops. Coming to the types of LVA. So we basically classify low vision aids into three categories: optical aids, non-optical aids, and non-visual aids. What are these optical aids? Optical aids are the ones that basically correct the distance or the near vision. So for distance, we'll have telescopes, contacts, pinholes. For near, we'll have magnifiers. And well, multifocal, that address both the distance and near vision. When we talk about non-optical aids, these are the things that will help us in enhancing the contrast and the illumination. We'll talk about this later during the slide. And then we have the non-visual devices, which help in a better rehabilitation of such patients. Like, for example, audiologic books, talking textbooks, talking BP machines. You just have to put the instrument and the machine will read it out to you. Coming to the optical aids. So they work on the principle of magnification. That is, they increase the retinal spread of these images. Now, there are two types of magnifications that we see. One is object magnification, which is as simple as that. You increase the object size. Like if you can't see from a small cup, give a bigger mug to the patient. Then coming to image magnification, where you increase the image size. Now this again is of two types, where there is approach magnification and there is angular magnification. Approach magnification is the one that is very, very important in terms of optical aids. Why so? Because again, if you can't see, go close. So here, there are a few examples along with the images. The first one is you magnify the object. For example, a deck of cards right here. You increase the size of the cards or the numbers written on the card so that the patient with visual impairment can see them properly. And here, if you can't, like this child, he can't read from a distance. He has to just come a little bit more closer to see better. And then angular magnification. Angular magnification is basically seen in distance correction, where we prescribe telescopes. So the disadvantage of magnification is that they provide a smaller field. The working distance is closer and sometimes it gets uncomfortable for long periods of time. Magnification needs more illumination. It also causes glare if there is more illumination. And there is difficulty while using the magnifiers. So coming to the telescopes that we use for distance, there are basically three types. The first is a handheld telescope. Second is spectacle mounted. Now spectacle mounted can be monoocular or binocular. The handheld one amongst these distance telescopes is the best one because it will provide us magnification from as minimum to 4x to maximum to 8x. The spectacle mounted ones usually provide up to 3x. So the principle of telescopes. So there are basically two principles of telescopy. Here there is Galilean or Keplerian. Keplerian one is the astronomical telescope. Both have their own advantages and disadvantages. The Galilean one is usually short and you can carry it around with you anywhere you go, but the field size would be smaller. The Keplerian telescope is longer, but it will provide a better magnification. But it's difficult to carry, and it is the advantage here again is that it will give a better field size. So advantage of telescopic correction is that it is the only optical system for distance magnification. It causes a dramatic improvement in visual acuity and allows independent travel of the patient. The disadvantages are that it's conspicuous, heavy, expensive, limits the visual field, and you have to be closer to the object. You cannot use it on a longer basis because it causes discomfort. The motion gets magnified, there is no depth perception, and of course, there's a big cosmetic issue with these telescopic uses. And yes, it is not safe for walking or driving. So this was a study conducted back in 1982 by Dr. DESAI, where we saw that when we correct, so a patient who presented with a visual acuity of 160 got corrected up to maximum to 624 with a low vision aid distance correction. So as the chart progresses, you can see that the better the presenting visual acuity, the better the improvement with the distance low vision aids. Coming to the near vision devices. So we have these handheld magnifiers, illuminated magnifiers, dome magnifiers, and different types, a different panel of magnifiers. So first we'll be talking about the handheld magnifier. You'll find them in ranges from 1x to 20x. They are inexpensive, easily available, you can carry them anywhere. The reading distance is normal. No spectacles are needed for a patient to use the handheld magnifiers, and even if the patient wants to use a spectacle, it is just going to enhance the vision. The disadvantage is that it's a smaller field. One hand is always occupied because he's holding the magnifier. You can't use it for long because it causes discomfort, and there are aberrations with higher power. So, okay, now there are these stand magnifiers also. These are used in cases with patients with tremors, like for example, Parkinsonian cases, where if the patient's hand is trembling, he won't be able to read. So you just put the stand on the thing that the patient wants to read, he can read it easily. So advantages here of these stand magnifiers is that they are steady held on a reading surface. The object is always in focus. The field of vision and the magnification are constant. That acts as an advantage as well as a disadvantage because the field is small. And another advantage is that it can be used at a normal reading distance. The disadvantage of these stand magnifiers is that it is inconvenient to carry. You can't carry a big stand magnifier always around in your pockets. You cannot use it on an uneven surface. Hands again are not free sometimes, and illumination may be a problem. Now there are another magnifiers which are best suited for children are these spectacle magnifiers. They come in various types and various powers, and they can be the spectacle magnifiers basically are 4 types. You have a convex sphere, the aspheric sphere, the clip-on loops, and the half-eye frames. These spectacle magnifiers, they provide the widest field of view. Now this was a case who had come. He was a case of glaucoma with one absolute eye, and he was studying in 12th standard, and he wanted to clear his exams. So we prescribed him a spectacle magnifier, and fortunately he passed with flying colors. Similar cases we keep on getting in our clinics, so this is one case where we gave a monocular spectacle, and this is a binocular correction given to a patient, and their quality of life improved. Again, so now this is a dome magnifier. So this is used for those with a constricted visual field and for those where there is tremor or poor coordination. These are available from 1.8x to 6x. Then these are Fresnel lens magnifiers. So basically these are magnifying sheets. So what you can do is, so they give because the size of the sheet is bigger, they'll give you a better view and a better field of view to read the object. Then there are magnifying rulers or bars which are specifically designed to read newspapers. So advantages of these are that they provide a constant magnification. They can be used in addition to the spectacles. They offer a good binocular vision. However, the disadvantages are that the lens must rest on a flat surface, and the diameter of these lenses limits the field of vision. Now, as I was talking about CCTVs, so this is pretty interesting that now we are used to hearing that CCTV cameras are used to spy around in the house or anywhere, But these things can be put to advantage in cases of low vision patients. So what they do is they use the concept of reverse polarity and they magnify the size on a screen. So there's a camera right here, and it is going to take the image and magnify it on a computer screen as long as to 40x. So you can adjust the size, you can adjust the brightness, and you can adjust the contrast as per the needs of the patient. So there are various modifications of these cameras also, which can be used at a student's desk so that he can see properly in his class. Then there are certain large print softwares like the Zoom Text Fusion. So these allow a patient to use the computer. So what they do is, if you install the software, it's going to enlarge, like you can see on the screen here. This computer screen is pretty enlarged. Everything for us, it'll be like, "Arey, kitna bada hai." But then for a patient with low vision aid, this is actually what they need to see. Now here again, like the similar study where we concluded with the near low vision aids as well, that a patient who presented to us with N48 with a correction with a low vision aid could reach up to N6. So now these three are the most useful optical aids that you need if you want to start a low vision clinic in your own hospital. So you need a handheld monocular telescope, hand magnifiers, and prism glasses, and that's it. And that's you can simply start providing low vision aids in your clinics. So now coming to the ubiquitous smartphone. So now there are I think iPhone 3S was the first one that involved all the visual aspects of using the phone. So now there have been many recent advances, and there are certain apps also which you can install on your phone. There are certain phones which are designed for people who have low vision. So here again, the text will be larger, the zoom option is easily available, then the cameras will have HD magnifiers, and there will be always a digital assistant telling you you can tell the assistant that what you want to do, and they can do it too. Like for example, you want to call XYZ, they'll call it for you. You don't need to see in the phone. And then there are these apps called the CI, Seeing AI, Soundscape, Lookout, Be My Eyes. So all these apps also help people with low vision to enhance using their electronic devices. So Be My Eyes is one such app. So what it does is, like for example, if a patient cannot see what is there in front of him, he doesn't know if it's an apple or a tomato, it's just he's gonna take a picture, send it to somebody on Be My Eyes, and they are going to tell what he's seeing in front of him. Coming to these non-optical aids, they are basically large print text with N18. So here again, large print telephone dials, clock dials, then again these remote controls, you have big large print controls. So now this is a very important non-optical aid. Number one is this is a notex. What it does is it has these various steps, and these steps are marked with the amount, number. So what you have to place a note here at the bottom, and the edge of the note, at whichever number it comes out, it will tell you that first one, if it comes out at the first one, it's a 5 rupee note. If it comes out at the second one, it's a 10 rupee note. Similarly, there are typoscopes which help the person to type or read better, so that you can see here it uses the principle of contrast enhancement. There is a letter writer, there are signature guides, there are talking watches, then there are these needle threaders which you can use, and again braille style boxes. Now coming to the non-visual devices that patients with low vision aid need are mainly canes, which can be simple canes or they can be ultrasonic canes, and guide dogs. So what these ultrasonic canes do is, they won't provide a longer range, but while a patient who is blind, who's legally blind, is walking around with a sonic cane, the ultrasonic waves can detect any object that is there in front of them and give them a signal in their hands by probably vibrating or talking, or like there's a speaker there, and they can know that, okay, there is an obstacle in front of me, either I have to turn left, right, or stop where I am. Okay, now we'll go to prescribing the low vision aid. I hand over to Dr. Sanjeev.
And this is the reason actually why you're here, to learn how to actually prescribe optical aids in a patient who has low vision. How do I change the slide? Okay, down here there's an arrow. Uh-oh. Right, so there are only 4 steps to remember. Okay, the first step is to record vision. Step number 2 is to predict what magnification does the patient require. Step number 3 is to select the device and offer it to him, test it out on him, and step number 4 is to train the patient in using the device. So let's look at all these 4 steps one by one. There are some slides which are missing, but anyway, in step number 2, you need a testing kit, all right? Because you need to test what kind of magnifier is required by the patient. So this slide is actually misplaced. So I'm going to speak a few lines about this and then carry on to the other ones. In our clinic, we have a Keeler low vision testing set, one for near and one for distance. But this is very expensive. I don't recommend it to you. We can use simpler and cheaper testing devices which are available in the country from Baliwala and Homi and from various other vendors. There are quite a few stalls in the exhibition here which provide low vision testing kits. If you are keen, you can check them out. They come as low as 10,000 rupees, even less. And as Dr. Devanshi has told you, there are only 3 good optical devices that you need to start a low vision practice, which is a handheld telescope, a set of hand magnifiers, and spectacle magnifiers, all costing about 8,000 rupees or so. So that is the amount of money you require to start a low vision practice in your clinic. Right, so step number 1 was determining the current visual acuity of a patient. So if patient has low vision, very poor vision, and if you're using the regular Snellen's chart, you will require huge optotypes like this on your chart, which is practically impossible. So what you can do is, number 1, you can use the conventional Snellen's chart in your clinic and test acuity at a distance which is very close to the chart. All right, maybe 5 feet or 3 feet away from the regular Snellen's chart. Or you can use special low vision charts. Okay, so if I have a few slides, I'll show them to you. Otherwise, we'll stick to the conventional chart. Right, so I have actually a few slides of the special charts, and this is only for the sake of completeness that I'm showing you these charts. We don't use them. We used to, but not anymore. We don't use them in our practice, but we have them in the clinic. This is the Keeler chart for distant vision recording, and it is used at a distance of 3 meters from the patient. And this is the Keeler near vision chart. No need to bother yourself about these charts. This is the Bailey-Lowy chart. The ETTRS chart is derived from here. It was first invented for low vision patients. Then these are 2 charts for near vision, specifically designed for low vision clients. The left one is called the Minnesota Reed chart, and on the right you have the Lighthouse chart. Fancy names, stick to your regular Snellen's chart and the near test book. So with a conventional Snellen's chart, how do you record the distant visual acuity? You make the patient sit at a comfortable distance from where he can read, which may be 10 feet, which may be 5 feet, or which may be 3 feet. So supposing he's sitting at 5 feet and you test him and he reads only the top line of the chart. And if you're using American notations, it is 20/20 top line. So you convert that figure by a suitable digit into the regular Snellen acuity. For instance, in this example, if the patient sits at 5 feet, reading the top line, you multiply it by 4 by 4, you get a figure of 2800. That's the Snellen acuity for him. Or if you're using the British system, then you make the patient sit at 3 meters and he reads 3 lines, 624 line at 3 meters. Then you convert it by multiplying it by 2 by 2, and that becomes a visual acuity of 6 by 48. So you have now recorded the vision of the patient. So far, so good. Good job done. Step 1 completed. And near vision, of course, you record with your near vision chart, the regular one which you have. So how do you predict beforehand what kind of magnification the person will require? Or no, before that, something is wrong. Okay, never mind. So there are two ways in which you can prescribe distant telescopes. Number one is thumb rule. In thumb rule, you just give a telescope of 2.5x to a person who has got visual acuity of 612. For lower visual acuities, you give, oh, I think I've got it here. Yeah, sorry. So two ways, as I said, one is the thumb rule and the other is to predict the actual magnification. The first and foremost thing you need to do is to give a spectacle correction, because as Dr. Devanshi has mentioned, once you give a spectacle correction, it increases the sharpness of the retinal image, which is very, very important. And in 10% of patients, it will improve the visual acuity too. The second thing to remember is that you avoid a distant telescope if the mobility is good. If the patient has vision like 560 and he's navigating properly in the home or outside on the streets, you don't want to encumber him with a telescope. So remember that if the mobility is good, avoid giving him a telescope. And number three rule to remember is you prescribe a low vision device which has the lowest useful power. So coming to rule of the thumb, if the vision is greater than 660, you straight away give him a 2.5x telescope. And if the vision is less than 660, you give him a 6.8 or an 8x telescope. An 8x telescope is one of the most useful ones. And if that is the only telescope you have in your clinic, you can test the patient on that and straight away give it to him if his vision is less than 660. So that was thumb rule, without having to predict or without having to know much about low vision optics. The second method of doing it is to actually predict beforehand what kind of magnification the person requires and then testing it out and handing it over to him. So the first thing you need to do is to set a target acuity. Target acuity is the acuity which the patient desires or which you think is good for him to see. So if the patient is undecided, doesn't know what kind of vision he wants, then you can take 612 target acuity as a ballpark figure. And the reason is that 612 is a vision in which a person can perform normal tasks in an outdoor milieu. And in America, they also require 612 vision for driving. So that is the vision you want to aim for. So take 612 if the patient is undecided. Then the magnification that you require to give is predicted by the formula given over there, that the desired visual acuity must be divided by the current best corrected visual acuity. So for example, if you want to improve the vision from 660 to 6.6, then the magnification required is 6 by 6 divided by 660, which is equal to 10x. So a 10x magnifier is what you will prescribe to this patient. So this is a very simple thing to do if you want to predict the magnification and then prescribe the low vision device. What you can also do is you can go one step up or one step down the predicted magnification, which is 10x in this case, and then prescribe a low vision device which the patient finds satisfying and is comfortable with, and you are happy that he is all right with that optical aid. Now you can also predict what kind of near device a person will require. And this was beautifully described by Dr. Kestenbaum in the late 1950s. And the rule is very simple. If the patient wants to read a newspaper, which is about N8 vision, then you take the reciprocal of his distant visual acuity. For example, if the patient has distant acuity of 660, then you take a reciprocal of it, which is 60 by 6, which is 10. So you prescribe a 10 diopter sphere for near correction, which is about 2.5x. Okay. For N6 vision, you multiply the reciprocal vision with a factor of 1.4. And for N4 correction, you multiply the reciprocal visual acuity by a factor of 2.8. But always remember the bottom line. Whatever you are doing, you have to subtract the available accommodation by 8, 6, 5, 3, or 1 diopter depending upon the age, which may be respectively 10, 20, 30, 40, or 50 years. The second thing to remember while applying the Kestenbaum's rule is that it doesn't work well in people who have got central scotomas. For central scotomas, you have to actually give twice the predicted magnification by Kestenbaum's rule. So remember that central scotomas, you'll need more than this. Rest of the cases, the rule works well. So these are the steps in prescribing near low vision aids. The first thing to choose must always be a spectacle magnifier. The reason we have told you, obviously it has got the widest field of vision. It is unobtrusive. People like wearing spectacles, no matter how thick they are, because it doesn't make them stand out. So the first choice would be a spectacle magnifier. The second choice would be a hand magnifier, and both of them can work together also to increase the magnification. So remember that. The third is a stand magnifier, and that is given only in those patients who have got tremors and can't hold a hand magnifier properly, those who have arthritis, or those who require prolonged near tasks, because then hands will fatigue. Telemicroscopes are given to those patients who require extended working distances, like school kids. They need to read and they need to write, so they have to hold a pen. So their distance from the textbook or the copybook should be larger. So that is the reason why you provide telemicroscopes to them. Then normally young children read large print books in school, and large print books are 18 point in font size. So you prescribe large print books for those low vision children or clients who are able to read only 18 point text and not less than 18 point text, even with high plus ads at 2 inches distance. So that is another thing that you need to remember. Then CCTV is prescribed when 18 point text is not visible, even with high ads of up to plus 32 diopter sphere. And if all these fail, that is the time when you refer the patient to a blind school and tell him to learn Braille. So great going. We finish the third steps, 2 and 3 steps in prescribing optical aids. And there is only one more step remaining, which is training in the use of the aids, which is very, very important, because a lot of patients cannot use the aid properly. They'll go home and they'll come back to you in 2 or 3 days' time. Ke saab ye wapis le lo, give my money back. Telescopes are very expensive. 15,000, 20,000, the cheapest one are about 8,000. So it is important that you train the clients. So spend some time in the clinic with the patient and ask him to use the device in front of you. Take him out on the street and make him use a telescope in the street, identifying street signs, street lights maybe, and ensure that the device works for the intended task. In your clinic, you can ask the patients to read some books and magazines if you're prescribing a near device. And final prescription is only given after patient and your own satisfaction. That both must be happy that the device is really useful for the client. So that's great. You finished the 4th step of prescribing optical devices. So 1, 2, 3, and 4 steps. Record the visual acuity, and then predict the magnification, provide the device, and provide training to the patient. So how much do these optical devices cost? That is a natural question which would come to your mind. And a spectacle magnifier would cost something like 500 rupees, and a distant telescope would cost something like 2,500 to 8,000 rupees if you're buying the inexpensive models, which are Japanese models or Korean models available in the market. So this is a table which shows you how much each of these devices costs. This is a rough figure. Now the next question which will come to your mind is, where would you get them from? I've got no financial interest in these products mentioned, but Baliwala and Homi in Mumbai was the first person to make a low vision testing kit and provide low vision devices in our country. 30, maybe 40 years ago he started doing this. And then there's Madhu Optics, Madhu in instruments in Delhi, Akriti Optical Plastics, Lensel Optics, and a couple more. Now remember, providing optical devices is not the only solution for low vision clients, because there are times when you might have clients with significant other disabilities and profound visual loss, especially young children, and for them you'll have to refer them to other medical professionals, social workers, special teachers, and occupational therapists for their treatment. So never hesitate to refer to the appropriate specialist if you can't treat them solely with optical devices in your clinic. So environmental adaptation is very important because they require tactile sensations to walk, especially if patient is profoundly visually impaired. And so you have tactile floors. You find them in the West, in the European countries, in Japan also you find tactile flooring. Even in the streets, you have the pedestrian walkways, and they will have this tactile tiles on the ground to assist low vision patients and blind patients to navigate the streets. And when I was building the new wing in my hospital, you can see I've put contrast lines all along the walls. So low vision patients can follow and be easily guided to where they are going or where they want to go. So that is the end of section 5, and we come on to section 6, which is about light, contrast, and glare, and how to manage it. So, you know, everybody requires light to see. And you might have noticed, if you're presbyopic, or even if you're not, if you've got normal vision, if you're reading, if you increase the light in the room, you'll be able to read better, because that improves the contrast of what you're reading or seeing. Likewise, low vision patients will require higher amount of illumination than normal patients. So the table over there shows you what is the normal illumination required for daily tasks. Reading requires about 400 lux, classrooms require about 300 lux for normally sighted people. But people with low vision will require much higher light illumination, somewhere around 1000 lux to begin with. And high intensity diffuse illumination of 1000 lux is what usually most low vision patients will require. And this will help them break through the mistiness of their vision. How can you provide such high intensity of light? There are two ways: natural light and artificial light. So in natural light, you can have illumination from a window. Like you can see this patient sitting in front of the window and with her back turned towards the window. So on a bright day, sitting near the window will provide about 10,000 lux of illumination. And on a cloudy day, about 2,000 lux, which is quite sufficient for a low vision patient. When you're using artificial lights, remember the picture on the right hand side, it's a gooseneck lamp. You can twist and turn it and make the light focus exactly where you want on the object of regard. You can bring it close, you can take it away and point it in any direction you want. So how do you provide 1000 lux? The bulbs which are available in the market are 60 watts, 100 watts. You don't have commercially available bulbs bigger than this unless you go in for industrial lighting. So the simple thing is to remember the formula over there. I is equal to Cp divided by D square. Here, I stands for illumination in foot candles, Cp luminous intensity of source, and D is the distance of illumination from the light source. That is where an adjustable lamp comes into play. So now you use this formula and you play around with the wattage of the bulb and the distance of the bulb from the object of regard. So if you have a 100-watt bulb and you keep it 1 foot away from a book that the person is reading and you apply this formula, you will get 1000 lux of illumination. If you put the same bulb 6 inches away, you'll get 4000 lux of illumination. Now if you have a 200-watt bulb in the lamp and you keep it 1 foot away, it will provide about 2000 lux, and the same lamp at 6 inches distance will provide 8000 lux of illumination. So there, it's as simple as that. Now, there are some things that you need to remember when you're considering artificial lights for your low vision patients. Number one is consistency. There should be no flickering in the light. The disadvantage of CFL bulbs and tube lights, even some incandescent bulbs, is that they flicker, right? So flickering is bad because it produces accommodative fatigue. So always have two lights in a row, as you can see in the picture over here. So multiple fluorescent lamps need to be installed, or multiple incandescent bulbs need to be on the ceiling. The second thing is source deterioration. Most incandescent bulbs have got tungsten filaments, and that decays with time. So after every few months, you have to keep replacing the bulbs or cleaning them of carbon deposits on top. The source is also very important. One must always choose an incandescent regular yellow bulb like that over a CFL or a fluorescent tube. The reason will become very clear in the next slide. And the fourth thing to remember is the background illumination must be 20 to 50% darker. Right, so this is the emission spectrum of an incandescent bulb. You can see beautifully that a large area of it is in red and yellow. So this mimics natural light. And there's very little blue, as you can see. But if you look at the CFL bulb, you can see a blue peak over there. So it emits a lot of ultraviolet and blue light. And if you look at LEDs, like the ones you have up here, there is a very sharp and prominent blue peak. So CFLs and LED bulbs emit a lot of blue light, and blue light, when it is scattered in the environment, will reduce contrast, and it will be very difficult for low vision patients. Those patients who have got glaucoma or AMD will have reduced contrast to begin with, and if you ask them to work in a LED environment, his contrast will be reduced further and will be no help to him. So remember, incandescent bulbs are always better for the low vision client than LED bulbs. So there's this famous biblical saying that God said, "Let there be light," and there was glare. And as you know, with glare, there comes a drop in contrast, which is very bad for low vision patients. So for all low vision patients, you must test and provide for these. You must increase their contrast and reduce their glare. So how can that be done? Oh, we are running ahead. Right, so glare, when it's from natural light or whether it's from artificial light, it can be treated. Indoors, outdoors, a patient can wear a hat with brim or use sunglasses or visors, and indoors, one can use blinds and curtains on windows or tinted glass on windows, or work with back towards the window. So these are very simple solutions to avoid glare in low vision patients. But you have to teach them. Most people don't know about this or don't realize that this can be done. So you have to tell them about it. The other thing is to use absorptive filters. I think I'm running ahead again. No. So these absorptive filters also reduce glare and improve contrast. And there are basically 5 types. As you can see from top to bottom, they are gray, amber, orange, yellow, and plum tints, right? The first one on top, the gray one, and the one at the bottom, which is plum, they reduce the overall transmission of light. So they are excellent protectors from glare and can be used outdoors. And the other 3 in the middle, which is amber, orange, and yellow, cut off the blue light, as you know, blue blocking IOLs. So they block out the blue light and improve the contrast. So for contrast enhancement, amber is the best, followed by orange and yellow. Then let's discuss a little bit more in details about these absorptive filters. The material of the gray one is Polaroid. All the rest of them are polycarbonate. All 5 of them block UVA and UVB 100%. The gray Polaroid one blocks up to 400 nanometers of light and provides true color representation. It's an excellent anti-glare filter for outdoor use. And the other ones are medium range blue light blockers and they are ideal for contrast enhancement. The one in the middle column for outdoor use, the one on the right-hand column mostly for indoor use. There are no disadvantages to the Polaroid gray filters, but the rest of them, in them, when you use these filters, blue color appears black and green is not seen when a patient wears these filters. So one must inform the patient about this, otherwise he'll come back running to you. कि साहब कम दिख रहे हैं color. Right, so Devanshi has got another session to attend, so I'm taking up her section. You see, when there's a low vision child, and if that child has got a lot of motor development problems, orientation problems, decreased life experiences, and decreased scholastic performance. So that is the reason why you need to treat a low vision child as early as possible. Now, how do you know that a child has got low vision? It's very difficult because children, very small ones, are pre-verbal, they cannot talk. They won't tell you that they can't see well. So for that, you need to know the visual developmental milestones and need to know whether the child is following those developmental milestones or not. And if he's not or she's not, then you at once come to know that he has got visual impairment, maybe a very profound one. So these are the milestones to remember. At 29 weeks of gestation, yes, when the baby is in the womb, the pupillary reaction to light is present. Fixation and horizontal following of moving objects, horizontal tracking is present from birth to 1 week. Vertical tracking occurs from 4 to 8 weeks, blink response in 5 weeks, and by 3 years of age, the child will have 6/9 visual acuity. And if these milestones are not followed, the child has visual impairment. So vision assessment is difficult in children, but not impossible. In early infancy, up to 4 months, you can check for pupillary reaction to light, head turn towards a light source, or blink response to bright light. For infant and pre-verbal children, you can use the Catford's drum, preferential looking tests like grating acuity, visually evoked potentials, and in verbal kids, you can use tumbling E, HOTV test, Sheridan-Gardner, Leah symbol tests, and there are a host of other tests which one can use. So for kids, assessment of the functional vision is very, very important. Now, what is functional vision? Functional vision is the purpose for which the vision is being used. So in little kids, you can't test their visual acuity. So you need to know what level of vision he's got. First of all, whether he's got any vision or not. If it is present, what level of vision he has got, and what is he using it for? So that forms your baseline from which you can prescribe your low vision devices. So for that, you'd have to test fixation, eye movements, and see what kind of work he can do or activities that he's doing. So this is all detailed stuff. It will take an entire lecture on its own. So I'm just going to avoid going into details. Just remember that the functional vision assessment of little children is very essential. If you can't perform, which probably most of us won't perform it in our clinics, one can always refer